Right. Good afternoon. My name is Maddie Helton. I am a senior associate on the prevention team at NASTAD, and I am so pleased to welcome you to the first webinar in NASTAD's Ending the HIV Epidemic Encore webinar series, which is called PrEP Landscape Updates. This webinar is supported through PS19-1906 funding provided by the Centers for Disease Control and Prevention's Division of HIV Prevention Bureau. We are joined today by a phenomenal panel of speakers from across teams at NASTAD to examine recent updates regarding medication and 340B pricing, access mechanisms, telePrEP, and policy updates. We will have time at the end of our presentation for questions, but feel free to send them in the chat throughout the webinar. That being said, I'll introduce our facilitator for today's call, my colleague, Rodderick Sheppard, to introduce our first speaker.
Thank you, Maddie. Hello, everyone. Rodderick Sheppard here, manager on the prevention team. My pronouns are he, him, his. And so today we have Tim Horn coming up as one of our first presenters. Tim will be going over the PrEP pricing overview and updates. Hey, Tim.
Great, thank you, Rodderick. Good morning, good afternoon, all. My name is Tim Horn, and for those of you who don't know me, I am the Director of Medication Access at NASTAD, primarily working on our healthcare access team around Ryan White Part B and ADAP issues, but also do have the great fortune of working with the Dynamite Prevention team on a lot of PrEP pricing, PrEP access, PrEP financing issues. So it's a really great pleasure to be with you all today. And my pronouns are he, him, his. Next slide, please. Okay, so PrEP pricing and costing issues have been identified as important structural factors associated with access to PrEP services, including the medications that have been approved by the U.S. Food and Drug Administration for the primary prevention of HIV. And as we illustrate in this slide here, these pricing and costing dynamics, have been important areas of research, awareness, and activism, not to mention public health program implementation over the years, including an ongoing effort to implement a national PrEP plan to provide comprehensive and, no less importantly, defragmented PrEP services to uninsured and underinsured people vulnerable to HIV in the United States. And of course, affordability is among many facilitators of PrEP access and utilization, which also includes numerous individual, interpersonal, community, and institutional considerations that have been well documented in the literature and are, of course, a big facet of a lot of the programming that you are all working on in your respective jurisdictions. Next slide, please. Okay, so what are we talking about in terms of PrEP costs? So here are some high-level estimates of annual costs based on manufacturer prescription drug list pricing data and data from a CDC-funded costing analysis involving PrEP services provided by 2 community health centers in the United States. So list prices for generic drugs are in the ballpark of around $200 to $500 annually, with branded medications, including oral Descovy and injectable Apretude, in the $22,000 to $26,000 range annually. Now, in terms of ancillary services, which include clinic visits and laboratory fees, an additional $1,500 to $2,000 in costs can be expected annually. Next. So in terms of annual costs in total, depending on the drugs required, the services required, and clinics providing those services, gross costs, not necessarily client costs, can range anywhere from $1,800 to more than $28,000 per year. Next slide, please. So to provide a little bit more granularity, we thought it would be helpful to sort of peek behind the drug pricing curtain when it comes to each FDA-approved drug, including their list price changes over time, their 340B pricing for covered entities providing PrEP services, and their insurance reimbursement, including 340B revenue or savings that can be generated by 340B covered entities to support their ancillary PrEP services. So, beginning with brand name Truvada, the per bottle list price was only $648 when it was first approved for HIV treatment in 2004. So by the time it was approved for PrEP in 2012, the price had increased 78% to around $1,200 a bottle. Today, the list price is at around $1,835 a bottle, and it's approximately 183% higher than its launch price, though branded Truvada is rarely dispensed these days due to generic Truvada competition, which we're going to be talking about in a little bit. Next slide, please. Okay, so as for Descovy, approved for the treatment of HIV in 2016, and then for certain at-risk populations for PrEP in 2019, there's been a 50% price increase over the years, with a current list price of over $2,100 per bottle or blister pack. Next slide, please. Okay, so in terms of generic TDF-FTC or generic Truvada, we have a remarkable success story stemming from robust competition. Really, what we can see is a race to the bottom here in terms of pricing. So following the initial price of nearly $1,400, and it's really not unusual for first generic products to debut at list prices that aren't all that much lower than the brand name version that's on the market at the time. There are now no fewer than 10 generic versions of Truvada on the market, which has resulted in substantial price reductions. So right now, the average purchase price for pharmacies is around $16 a bottle, which is really a greater than 99% price difference compared to brand name Truvada as well as brand name Descovy. Next slide, please. Okay, as for Apretude, which is long-acting injectables cabotegravir, this was approved for PrEP in 2021. And the current list price is approximately $3,800 for each injection kit, requiring administration every 8 weeks. Next slide, please. Okay, so what about 340B and pricing as well as insurance reimbursement? So just a quick overview in terms of 340B. So generally speaking, in accordance with federal requirements, 340B covered entities are entitled to a discount of at least 23% off the list price, with additional mandatory discounts every time the average list prices increases faster than inflation. So at its peak list price, and around the time commercialization of Descovy was ramping up, total 340B discounting for Truvada was approximately 75%. So with commercial insurers reimbursing at 3% or so above the drug's list price, the total spread or program savings was substantial, nearly $1,400 per bottle of Truvada, purchased at around $442 per bottle. Next, please. Okay, so when it comes to generic drugs, 340B covered entities are entitled to a minimum 13% discount off of average manufacturer prices. And during the first year or so of generic TDF FTC's availability, 340B covered entities were enjoying some savings, given that it can take some time for insurance reimbursement rates to catch up with decreasing prices in the generic market. And today, generic TDF FTC can be purchased by 340B at around $14 or $15, and will probably net less than $500 annually in program revenue. Next, please. Okay, so with Descovy, we had an interesting 340B dynamic over the past several years. So at the time of its approval, 340B covered entities were entitled to a 40% discount in accordance with federal requirements, resulting in a net price that was substantially higher than that for Truvada. So the manufacturer provided supplemental discounting, ostensibly to promote switches from Truvada to Descovy without compromising 340B savings, resulting in 340B revenues per bottle in the $1,300 ballpark per bottle. So by 2021, however, the manufacturer began scaling back the supplemental discounts, And today, the statutorily required discounting applies, but given that the list price increases over the past several years, 340B covered entities are again seeing program savings around $1,300 per bottle. Next. Okay, so lastly, in terms of aptitude, and what I've done here is we've made this a little bit bigger for viewing purposes. 340B discounts are around 24% of the list price, with potential savings in the ballpark of around $1,000 per kit. Next. Okay, now one thing that's important to note is that some clinics are reporting insurance reimbursements that are actually below what they're actually paying for the drug, at least where 340B discounting isn't being applied. And this has been a really important affordability issue for some clinics and pharmacies, who are certainly having to contend with scaling up access to aptitude, because if they are in fact underwater, they're not receiving sufficient reimbursement from insurance, that can certainly be a challenge for them. Next, please. Okay, so to help us segue into the sort of the core presentations being provided by Nicole and Dori today, it can be helpful to think about pricing and cost against the backdrop of systems that can help finance and defray these costs. Now, when it comes to people living with HIV requiring care and treatment, there really is a comprehensive patchwork of employer-based insurance plans, individual insurance plans, including Affordable Care Act plans, Medicaid and Medicare, the Veterans Administration, and copay assistance programs. And importantly, and this really does require underscoring here, there is the Ryan White HIV/AIDS program, as well as AIDS drug assistance programs, which provide not only medical services, support services, and prescription drug access to approximately 1/2 of all people living with HIV in the US, but next, also provide premium and cost-sharing support for thousands of people living with HIV who are even better served by comprehensive public and private health insurance. Next. Okay, so when we look at HIV prevention and PrEP payer patchwork, we don't have anything quite comparable to the Ryan White and ADAP. Next. So instead, we're depending on a mix of programs to meet the needs of people who are uninsured, underinsured, or require assistance with out-of-pocket costs, which really can be significant. So, this includes manufacturer and charitable patient assistance programs. There's also the Department of Health and Human Services Ready, Set, PrEP program, which utilizes drug donations limited to Gilead drugs. There are also manufacturer copay assistance programs, though it's important to recognize that the maximum out-of-pocket, cost for ACA plans is currently in the ballpark of around $9,450 for individuals, whereas manufacturer copay assistance programs benefits are typically capped at around $7,200 to $7,500. There are also charitable and sliding scale fee care provided by community health centers and other community programs. And Nicole and Dori are going to be talking about the U.S. Preventive Health Services and what it means, what its PrEP recommendations means in terms of eliminating a lot of the client cost sharing we've been talking about. Next. Lastly, and before we turn it over to Nicole, I just want to reiterate that that PrEP isn't just a drug. It really is a set of comprehensive health services, all of which are associated with cost considerations that require robust systems of coordination to ensure affordable access for people in need of those services the most. So I will stop there and turn it back to Rodderick or over to Nicole.
Thank you, Tim. And for everyone in the audience, we are holding questions to the end. Feel free to start dropping any questions you might have in the comment section as well, because we're going to circle back around to those. And now moving on to access and PrEP overviews and updates, facilitated by a colleague that I work very closely with on PrEP-related items at NASTAD. Everyone, please welcome Nicole Elinoff.
Thanks, Rodderick, and thanks, Tim. And hello, everyone. Greetings, whether it's afternoon or morning. Really happy for you to join us on this Encore series. And Tim, thank you so much for that great overview of PrEP pricing and providing a really great segue to talk about PrEP access updates. So as Tim briefly mentioned, PrEP services should be covered without copayment, and that is due to the United States Preventive Services Task Force Grade A recommendation for PrEP, which was initially issued in 2019. And so with this recommendation, the Affordable Care Act patient protections require Medicaid expansion programs and commercial health plans to cover PrEP without cost sharing. So with PrEP, again, like Tim was saying, not only just the medication, but the services too, like the healthcare visit, the labs, the navigation, all the different support that is needed, because those items are integral services for PrEP. So USPSTF implementation really began with the 2021 plan year. And so PrEP is now an essential health benefit, and health insurance plans must provide PrEP without cost sharing. So in 2019, the first recommendation came out with the grade A, and it had the population of persons at high risk of HIV acquisition. In 2023, USPSTF issued an updated recommendation, specifically updating the population and recommendation to expand beyond only TDF-FTC, as that was the only FDA-approved form of PrEP at the time of that 2019 recommendation. Another thing I want to point out here is that USPSTF changed the language from quote unquote high risk to increased risk. And I wanted to make note of this, as high risk language can be really stigmatizing and is not included in the 2021 PrEP clinical guidelines by CDC. And so while USPSTF implementation began in 2021, as Tim shared in his slide, there are a lot of press articles showing that that's not necessarily actually taking place, and individuals are still paying out of pocket for PrEP when they shouldn't be. And Dori will be providing some updates on the legal challenges to USPSTF later on in the presentation. But as it stands now, USPSTF grade A recommendation is still standing. The USPSTF recommendation is incredibly important access consideration, especially for those with qualified health plan coverage. In April 2023, an estimate of insurance status in PrEP was shared in Health Affairs. And on the slide, as you can see, of the total individuals indicated for PrEP, approximately 63.6% have access to private insurance and 21% have public insurance. An effective USPSTF implementation can really lead to more accessible PrEP for this population, those with healthcare coverage. And we'll speak a bit more about this in the next section on billing and coding. And we'll also talk about some resources for uninsured individuals later in the webinar. So billing and coding, I'm going to ask y'all a quick question. And the question is, why is billing and coding such a big deal? And so in the chat, add, whether you think it's A, reimbursement for services because we got to pay the people, B, incorrect billing could lead to a big bill for patients, C, it supports program sustainability, or D, all of the above. So let's see what y'all say in the chat. D. Yeah. So, as Tim just mentioned, the generated cost savings for programs has dramatically changed. We've had such a big change in the landscape of PrEP over the last couple of years. And billing and coding is very, very important for all of the reasons that are on the slide. So reimbursement for services, as I mentioned, USPSTF grade A recommendation, people should not be paying anything out of pocket for their PrEP services. And so correctly billing and coding can really help lead to the successful implementation of USPSTF and making sure that not only are the providers getting paid for that visit, but that the folks are not getting a big bill, for a copay for their labs, for instance. Incorrect billing, like I just mentioned, could lead to a big bill for patients. One of the things that could really lead to someone not continuing their PrEP care is by getting a huge bill and not being able to pay for either their PrEP medication or the services they need for PrEP. And then also like program sustainability. So for programs that are not billing and coding right now for PrEP and getting reimbursements from health insurance plans, I really encourage you to start looking into this strategy for sustainability. As you know, as we've talked about, generated savings have changed over the years. So to address some of these billing and coding challenges, NASTAD released the updated billing and coding guide in October 2023. And we really started doing this update because of a lot of what we were hearing about USPSTF implementation and challenges with ensuring that all of the different services integral for PrEP, patients weren't getting a bill for that out of pocket. So if one of my colleagues will add the billing and coding guide into the chat, on that webpage, you have access to the webinar that came out introducing the guide, a frequently asked questions document, and then the guide itself. And this guide had over 40 people, be involved with reviewing it, providing input, and it's a really comprehensive resource. So what does the update include? The update addresses the USPSTF implementation. It also talks about long-acting injectable PrEP implementation, self-testing, post-exposure prophylaxis, troubleshooting claim denials, and much more. Very comprehensive resource. So if you haven't had a chance to review it or send it to your subrecipients, highly encourage that. This could be really helpful for them. The new tool also highlights the new ICD-10 code for PrEP, different HCPCS codes for PrEP, payer policies, NASTAD billing and coding for PrEP, including visits for PrEP and telePrEP and PEP, different modifiers, and then denial and appeal tools. So the real star of the show is the ICD-10 code for PrEP. This took many years to get, a code for PrEP services, and the code is Z29.81 and counter for HIV pre-exposure prophylaxis. It excludes desensitization to allergens and prophylactic surgery. And the code also notes that, if applicable, risk factors for HIV, such as contact with and suspected exposure to HIV, and also risk factors such as high-risk sexual behavior. So for Z20.6, we don't necessarily recommend it as the code description specifically states pre-exposure prophylaxis, and we think that it's a little duplicative to add Z20.6. And then we also don't recommend the use of high-risk sexual behavior as a code due to the stigmatizing language. And I know I'm going a little fast, but all of this information will be shared with you, and there's a lot of great information in the billing guide itself. Another resource that I wanted to highlight in the guide has to do with claim outcomes. So if a claim was denied with no payment to the provider and no cost share to the patient, we have some different resources that can assist with this, such as appeal letter templates. We also recommend to always review payer policies before appealing a claim to try and understand the denial reasons. Let's say the claim was paid, but the payment amount or the patient cost share deductible did not process as expected. NASTAD has an appeal letter template with different rationale and supporting resources, and we'll talk about the PrEP cost sharing complaint template in a second. So when filing complaints, it's important to think about what kind of plan does the individual have. So is it a qualified health plan? So did they buy it through the marketplace or in the ACA regulated individual market? Is it a group fully insured? Are they self-insured? Usually through a large employer, or is it a non-federal government plan? So depending on the type of plan will impact where the individual can file a complaint. So they could file a complaint with the plan itself, the benefits administrator, employer human resources, the Department of Labor, the State Department of Insurance, or Centers for Medicare and Medicaid. Another resource highlight is the PrEP cost sharing complaint template. This was released back in 2023, and it's been really helpful for programs and navigators to issue complaints to either the Department of Labor, CMS, or the state insurance regulator. So I talked a lot about the different billing and coding and some of USPSTF implementation considerations. We're really hoping that as more plans, as more billing and coding is more streamlined and the use of the new ICD-10 code for PrEP, that some of those challenges of USPSTF implementation can be alleviated. But it is a much bigger issue than billing and coding. And so, you know, all of us, if we can keep reminding individuals and programs that PrEP should have no out-of-pocket costs for patients, you know, and all help with enforcement can be really helpful. So public health funding, I'm not going to go into all the different manufacturer assistance programs that Tim mentioned, but I did want to talk briefly about public health funding. So some states have PrEP drug assistance programs, and PrEP assistance programs are pivotal in creating points of access and coverage opportunities where there's a lack of insurance or cost considerations can serve as structural barriers. So NASTAD is currently updating the PrEP assistance program directory. I have a screenshot of a table on the slide that we have on our PrEP access microsite. And we're going to be updating the information on the site as well as the table, and we're including information on doxyPEP, if programs are able to provide assistance for long-acting injectable PrEP, and we've also asked about post-exposure prophylaxis, HIV PEP as well. So please stay tuned on updates for that PrEP assistance program directory. There are also different federal grant support that could help with the PrEP continuum. And so on the slide, there is a crosswalk of federal grants and what expenses are allowable for PrEP. And so, for instance, we have marketing and awareness, HIV testing and PrEP evaluation, navigation services, lab studies, prescribing, medication, and retention and adherence support. So as you can see, red is unallowable. And so a lot of these cooperative agreements have that as medication as an unallowable cost. And then same with clinic visits, but some, such as the PS2010 and PS18-1802, have you know, limited and allowable for lab studies and prescribing. So with the changes of federal grants from PS1802 and PS2010, with the new PS240047, it doesn't ring off the tongue as easy as PS18-1802, but 240047, we are updating this document to include the change with the federal grants. And with the federal grant PrEP guidelines, they haven't really changed since they were announced in 2021. So there won't be that many differences in the updated PrEP crosswalk with the new cooperative agreement. So lastly, I want to talk about telePrEP, as telePrEP programs are particularly well poised to scale up and expand PrEP access to help meet goals and, you know, help address the HIV epidemic. And when talking about telePrEP, I'm talking about telehealth, utilizing telehealth in part or in full for provision of PrEP care. And so the goal of telePrEP programs is to increase access and retention for users who may not otherwise engage with or be retained in PrEP care. And telePrEP can really help at different stages of the PrEP continuum, from PrEP assessment, PrEP initiation, retention, and persistence. You know, love talking about the different telePrEP resources NASTAD has, but we really do have a suite of resources in the telePrEP online learning series. One module was recently made live, and that is the financial forecasting and program sustainability module. And it talks about some of what Tim mentioned. We have other modules in this series, such as using the 340B program for PrEP, telePrEP delivery models, promotion and education, at-home testing and lab contracts, and all of this is learning at your own pace with different pre-recorded videos and executive summaries. which I jumped ahead of myself. We have a whole bunch of items in the modules, including supplemental materials and different pre-recorded videos that are no longer than 20 minutes. And then it comes with different office hours and supplemental technical assistance opportunities. Some other upcoming telePrEP resources to keep your eyes out for. We have some items talking about third-party telePrEP programs. So the different resources will be partnering with a third-party telePrEP program, patient record retention compliance strategies. We have a document on evaluation considerations and decision-making tool. And then coming up soon will be the protective contracting best practices and operational considerations. If you want to keep talking about PrEP, stay tuned. Right after this webinar, we have a telePrEP office hour, which is monthly, and it'll be happening right after this at the top of the hour or 3 to 4 p.m. Eastern. And if you have any questions, you could always reach out to prep@nastad.org or to me, and my email's on the screen. I'll pass it over to Rodderick to introduce Dori.
Thank you, Nicole. Let me tell you, Nicole is a wealth of information as it relates to PrEP. So if you are in need of any assistance or having any questions, that is your girl you should reach out to. Thank you, Nicole. So next up, we have Dori that's going to talk about PrEP policy updates. Hey, Dori.
Hi, everyone. This is Dori. Thanks for having me. Sorry, am I doing my own slides here, or I wasn't sure?
No, I've got you. Just 1 second.
I'm happy to, so just let me know. Great. Thank you, Maddie. So today we're going to talk about some important PrEP policy updates. Next slide, please. I'll talk about the Braidwood versus Becerra litigation that's currently pending that some folks here might have already heard about. I'll talk briefly about NASTAD resources and other PrEP assistance resources to support with helping clients access PrEP, both physically access it and coverage-wise. I'll talk about NASTAD's research related to pharmacist-initiated PrEP and PEP, and I will close with an update on the Medicare National Coverage Determination, or NCD, which has also been floating around in the news and listserv, so folks might have also heard a little bit about that too. So let's get started. Next slide, please. I suffer slightly from allergies, so if I pause or cough or anything, just please excuse me and bear with me. So first, let's talk about the Braidwood versus Becerra case. So this case started with some employers who didn't want to pay for a health coverage that included certain services. Specifically, they objected to paying for coverage for their employees that included certain disease screenings and also that included PrEP for HIV prevention. According to these employers, they had allegedly moral and religious reasons for not wanting to pay for them. But unfortunately, they didn't have a choice because the ACA requires nearly all private plans, including the types of employer plans that these employers would have provided to their workers. All these plans must cover PrEP, and it must be covered without cost sharing. So the employers went to court to challenge the ACA, the Affordable Care Act, and its constitutionality is on trial yet again. This is a very highly litigated law, as folks are probably aware, and now we're having yet another iteration of attacks against it in court. So I'm not going to get too far into the legal background here, but I will just summarize the kind of primary argument and legal reasoning that's operating in this case. So as Nicole explained, the USPSTF's recommendations determine which services must be covered under the ACA's preventive services mandate. So since PrEP received an A rating, it therefore must be covered by the vast majority of private plans, including, again, plans that the plaintiffs, the employers, would have bought for their employees, paid for their employees. So one of the plaintiff's strategies in this case is to go after the validity of the USPSTF itself. So they're arguing that Congress inappropriately gave the USPSTF authority to make coverage mandates. And the reason it's inappropriate is because these members have not gone through a proper appointment process, which is something that the Constitution requires for certain types of government officials, for many types of government officials. So the argument goes, since the USPSTF members were not properly appointed, they never had the authority to issue coverage mandates in the first place, making the preventive services a mandate essentially invalid, and therefore the employers don't have to pay for coverage that includes the services that they don't like. To kind of illustrate how that works, if the appointments aspect is a little bit confusing, on the other hand, the judge in the same case found that mandates based on recommendations from other bodies, like the Advisory Committee on Immunization Practices, this body also makes recommendations about vaccinations and immunizations that plans are required to cover. The judge said that these were okay because they were signed off by the CDC director, and that person answers to the Secretary of Health and Human Services. So basically, USPSTF just kind of isn't just doesn't have the authority that these individuals would have, and they don't have the authority to make binding recommendations because there's not enough basically oversight and accountability of them is the crux of the argument there. So the current status of the case, about a year ago, a federal judge in Texas agreed with the plaintiffs. A year and a half ago, September 2022, a federal judge in Texas agreed with the plaintiffs regarding the question of the USPSTF's authority. If you guessed that it was Judge Reed O'Connor, you would be correct. It was appealed to the Fifth Circuit after that, where the appeal is currently pending. And until the appeal is resolved, the preventive coverage mandate will stay the law of the land for everyone except for the plaintiffs. The plaintiffs that brought this lawsuit don't have to follow it while the appeal is ongoing, but everybody else does. The Fifth Circuit said this, I didn't put it on this timeline, but June 2023, the Fifth Circuit said that the mandate is going to stay in effect until the appeal is over. Last month in March, the Fifth Circuit heard oral arguments. We don't know how long until there's a decision, but these things tend to take a bit, kind of a while, maybe as much as 8 or 9 months potentially. Next steps, we expect, since both sides are very passionate about this issue, we expect that there will be an appeal to the Supreme Court regardless of what the outcome is. So the loser is going to appeal in both cases, no matter what the outcome is what we expect. We also, just to kind of add some of my own commentary here, the Fifth Circuit is generally considered to be pretty conservative. These plaintiffs have, in all likelihood, intentionally chosen to bring the lawsuit here and in front of even this particular judge because they know that it's a relatively friendly environment for them. So I think while we remain open-minded and optimistic until the case is over, I think we should reasonably prepare ourselves for not a great outcome in the Fifth Circuit. Next slide, please. So the impact of a decision in Braidwood in favor of the plaintiffs, if the employers are to win, the ACA's challengers were to win, if they succeed and the USPSTF's authority is invalidated, then these, quote, morally objectionable services like PrEP are not even the only services that are at risk. Over 150 million people each year receive evidence-based preventive care without cost sharing. 60% of enrollees in private plans use preventive services without cost sharing each year. This includes a wide range of services that everybody needs to keep ourselves and our families healthy. Many of these are life-saving services, screenings for physical and mental health conditions in kids and adults, medication to prevent illnesses like heart disease or cancer, like statins, for example, preventive dental care for kids, and many more. Also, tests for HIV, hepatitis B, hepatitis C, and STIs would also be at risk. So if the Braidwood plaintiffs succeed, these services would no longer be mandatory under commercial insurance. And so we expect that insurers would then start eliminating covered services over time, and insurers that decide to keep covering them could still charge cost sharing for them. So it's an issue of coverage and also of cost. Even folks who maintain coverage might not be able to afford these services anymore. If plaintiffs succeed, it would also potentially risk coverage for the Medicaid expansion group, since USPSTF does apply to the Medicaid expansion group, not to other Medicaid beneficiaries. For other Medicaid groups, states make determinations for what preventive services will be covered. But for Medicaid expansion, USPSTF just applies to it. So what that means is that the Medicaid expansion is also at risk. Based on the analysis that I've been reading from experts on this, though, there is, I think, a good reason to believe that states will continue to cover these services under Medicaid. First, because they receive enhanced federal funds for covering USPSTF recommended services, as well as HRSA and ACIP recommended services. And also because, or maybe just for ACIP and USPSTF, my apologies on that. USPSTF for certain, they receive enhanced federal funds. And also, preventive services actually do save costs in the long term. So Medicaid programs, in all likelihood, do understand that. So lower income individuals are those most likely to forego health services due to cost, and are also more likely to experience the types of health conditions that these preventive services are designed to prevent. So as with many bad healthcare related policies that we do not support, the impact is expected to fall disproportionately on systemically marginalized groups. So what could happen to your client's coverage when there's a final decision in the case? Depending on the kind of employer coverage that someone has, their plan could change how much they pay for these services in the middle of the year, as long as they give 60 days notice. So with 60 days notice, a lot of employer plans can actually just make cost changes mid-year. But ACA compliant individual plans like the marketplace and then certain other types of employer plans generally cannot make mid-year changes like that. So enrollees with those types of plans would likely have until the following year to get ready for that change. This decision, again, does not affect all preventive services coverage mandates. There are some recommended preventive services that HRSA and ACIP recommend. These are, for example, the contraceptive mandate comes from HRSA, so that is a little bit of a relief here that one is not affected by Braidwood. So ACIP and HRSA, because like I explained, they don't violate the appointments clause in the way that USPSTF does, according to the judge and the plaintiffs. So those services would still be covered without cost sharing. And additionally, many states have codified the ACA's coverage mandates in their state laws, and those would continue to be valid. I think it's not even half of states that have this, maybe around a third that have a coverage mandate like this. So it's not like something that's going to help folks in every state by far. Also, a lot of employer plans are not subject to state insurance laws. So there are still a lot of people who would be left out in a state level coverage mandate, but at least for some types of coverage, there are, I think, roughly a third of states do have the ACA's coverage mandate codified into their laws. Okay, next slide, please. All right, that was definitely the heaviest and most difficult part of this presentation, so we made it through. I just wanted to share really quickly. I know my colleagues have already talked about some of our resources. Some of the resources that we have, I think, are specifically relevant to the preventive services and Braidwood issue. So I just wanted to highlight those for your attention. They're all available on our PrEP Access microsite, which I believe folks should all have links to, nastad.org/PrEP-access. These our tools can help identify patient assistance programs for patients that are underinsured, don't have sufficient coverage of PrEP or PEP. We will likely maintain some updates there related to Braidwood. So that's another way you can check to see if there have been any developments in that case. We have tools to help verify PrEP coverage under marketplace plans. Nicole talked about our template for filing complaints about uncompliant health plans that are charging cost sharing for PrEP. I think I also mentioned that there's, depending on the type of employer plan someone has, there may or may not be a mandate that applies to them. one thing that I really like about our complaint template is that it actually helps you figure out the right the right oversight body to go to when there's an issue with PrEP coverage. So I really appreciate that. Then that can be helpful for figuring out, where to start, because depending on someone's coverage, there might be a different process for dealing with noncompliance. And finally, of course, we have access to information briefs, guides, and webinars about timely PrEP-related law and policy topics, including pharmacist authority to prescribe PrEP, which I'll talk about in a moment, and some telePrEP and minor consent and confidentiality, and some of our other key law and policy topics. Next slide, please. So here I just wanted to highlight a couple of links for folks. Again, remember that Ready Set PrEP still exists. It is available for folks who don't have health insurance and are not eligible for Medicaid or ACA plans. Then there's some links here for the Patient Advocates Foundation, which is a great resource on patient assistance. Of course, NASTAD's microsite has information about patient assistance programs, and I also included a community health center locator here. Next slide, please. Okay. Next, I want to talk about the pharmacist-initiated PrEP. This is some work that my colleagues on our legal research team at NASTAD have been working on. I'm so proud of it. I think it's great. I encourage everybody to take a look at these resources. So pharmacists are consistently rated as one of the most trusted healthcare professionals, which of course makes them ideal providers of PrEP and PEP. So our legal research team has developed some resources here about pharmacy authority to provide PrEP and PEP. So I just wanted to talk a little bit about that work and some of those findings, and I'll just talk about PrEP for today to remain on theme, but know that these resources also have information about PEP. So only 30% of individuals who could benefit from PrEP actually use it, as I'm sure folks on this call are already aware. Uptake is lowest among the groups with the greatest need, such as rural Americans in the South, Black and Latinx individuals, serodiscordant couples. The barriers that contribute to this disparity include things like bias from healthcare providers, systemic racism, just reduced access, a lack of affordability, or even lack of knowledge about PrEP, or believing that it's not meant for you. So addressing these barriers is crucial to increasing PrEP intake, and community pharmacies in particular are very well suited to address these barriers to PrEP and to increase uptake, since they're a much more accessible option than traditional healthcare providers. 90% of Americans live within 5 miles of a pharmacy. Pharmacies often provide services for extended hours, some up to 24 hours a day. Patients don't need an appointment to go there. And pharmacists also provide important linkage and referrals to other healthcare services in the community. So for pharmacists to initiate PrEP, their scope of practice needs to be expanded so they can independently distribute PrEP. And there must also be legal requirements for proper reimbursement for pharmacies that are providing PrEP. While pharmacists in almost every jurisdiction have the authority to aid in initiating PrEP, the ideal legal route would be through legislation that specifically grants authority to initiate PrEP. In addition to outlining the contents of the legislation in the 13 states that do specifically allow pharmacists to initiate PrEP, we also looked PrEP and/or PEP. We also looked at laws in every jurisdiction on corresponding policies. So, for example, the ability of pharmacists to conduct CLIA waive tests. We looked at Medicaid reimbursement requirements for pharmacists providing clinical services. We looked at collaborative practice agreements, or CPAs, which are a common alternative for pharmacists that want to initiate PrEP. So I hope folks will take a look at these resources. I think that they're great. If this topic is of interest to you, I encourage you to check it out. We have an issue brief, an interactive map, and a database, so different formats for depending on your preference. And we do this work because we believe that by establishing the necessary legal authority, pharmacy initiated PrEP and PEP can become crucial strategies to increase uptake of these medications and ultimately end the HIV epidemic. Next slide, please. And finally, I know we're kind of low on time, so I'm just going to talk really quickly about a Medicare national coverage determination. In July 2023, CMS proposed to transition PrEP coverage, both oral and injectable, to Medicare Part B as a mandatory preventive service without cost sharing. There also the proposal also includes to cover without cost sharing a whole array of ancillary services, screenings, testing, etc. USPSTF does not automatically apply to Medicare. So for Medicare, for a service to be a mandatory preventive service under Medicare, the Secretary needs to issue a National Coverage Determination, or NCD. Also, because of the fact that USPSTF is not the source of the mandate in Medicare, that means that the Braidwood case should not impact PrEP coverage under Medicare. National Coverage Determinations, or NCDs, they only apply to Part B. CMS says that there is no mechanism by which it can mandate zero cost sharing for Medicare Part D plans, which are prescription drug plans. So CMS is proposing to move PrEP coverage out of Part D. Well, oral PrEP is currently covered under Part D, and so that all PrEP and all is covered under Part B instead. This would give CMS like the hook that it needs to actually mandate coverage without cost sharing for Medicare enrollees. According to CMS, this is the way that it has to be done. So currently, oral PrEP is covered by Medicare Part D because ARVs are considered a protected class. This means Part D plans must cover oral PrEP, no utilization management, like prior authorization or step therapy. But even though it must be covered for all Medicare enrollees, plans can charge cost sharing, so it could still be out of reach financially. Injectable PrEP is, on the other hand, is already covered under Medicare Part B, but it's not mandatory. So whether or not it's covered for a Part B enrollee depends on the local coverage determination, or LCD, for their region. Medicare Advantage plans might also choose to cover it, but they're not required to. So in sum, right now, Medicare enrollees who want PrEP, they might not have access to injectable PrEP as an option, or they might not be able to afford PrEP at all because of the cost sharing. Under this proposed NCD, oral and injectable PrEP would be covered under Part B with no cost sharing for all Part B enrollees. And I just want to clarify quickly here that this only applies to when the medication is used for PrEP. When the same drugs are used for HIV treatment or PEP, they'll consider to be continue to be covered under Part D. Next slide, please. This is my last slide, but I just wanted to pause and see if if there are questions that are pending, because if so, I can pause here and we can address that, or I can highlight some points about the slide. Okay, so perhaps there are no questions, so I will keep going. So finally, just wanted to highlight some potential challenges with implementation of the PrEP Medicare NCD. If and when it's finalized. So I'm going to present these in the frame of public comments that were submitted by HIV advocacy groups. So in these comments, the community urged CMS to, at least these groups urged CMS to ensure that the NCD coverage of the ancillary services is consistent with current PrEP's guidelines for CDC. From CDC, I think Nicole explained a little bit earlier that even with USPSTF in place, we know that not all of these ancillary services are being covered properly. So, ensuring that all services consistent with the CDC PrEP guidelines are covered is definitely a really important recommendation. Commenters also highlighted that the NCD has some stigmatizing language in it. It refers to PrEP candidates as being individuals who are, quote, at high risk for HIV. According to the commenters, I don't disagree. This is stigmatizing language in and of itself, and also forces people to detail their reasons for wanting PrEP, which can be a deterrent. So the comments suggested that CMS modify this language to better reflect the CDC guidelines. And the CDC guidelines recommend that discussing PrEP with all sexually active adults and prescribing it to anybody who wants it. We're also keeping an eye on how the final NCD addresses potential patient access barriers. So for example, making sure that utilization management is clearly not allowed, making sure patients can still access mail order pharmacy and telehealth, making sure patients can still get enough day supply when the drug moves from Part D to Part B. And ensuring that there are enough pharmacies that can build a Part B. There are a lot of pharmacies already, I think 60 to 70%, that are already set up to bill Part B for PrEP. But since drugs are typically billed as Part D, there are a good number of pharmacies that also still need to enroll as a Part B provider in Medicare in order to be able to bill for these services. So making sure that there are as few barriers as possible to pharmacies doing this is also very important. And yeah, I think we're going to continue monitoring developments related to this and to Braidwood, and we'll keep folks updated accordingly through our listserv and other resources. So please stay in touch and keep an eye out for more from us. And I think that's it. I'll turn it back to Maddie.
All right, all right. And so we're running out of time. I'm gonna quickly talk about the PrEP navigation group, and I don't have any slides. It's still fairly a new group in NASTAD. We're barely a year old. Going through the first cycle. So the PrEP Navigator peer-to-peer group is a space for each phase 1 jurisdictions, NASTAD members, and community level staff of PrEP navigators to meet and discuss topics impacting PrEP access, share resources, and learn from each other's experience. So my last session, we had a really good conversation last month around PrEP navigation for patients who use drugs, and we invited our drug user help team in to be a part of that conversation. We have our next session coming up on May the 28th. So if you want some more information about that, my contact information, and Nicole is also a part of the team. You can reach out to either of us to get that information. We haven't released the registration officially yet, but we will so within the coming week or two. And so I just wanted to plug that before we get into any questions that people might have. I see that some of the questions in the comment section has been answered throughout the session, but are there any questions where people want to, come off mute and address the question? And also I'm gonna take a look at the comment section to see whatever questions that we have. And yes, the attendees will receive a copy of the presentation and the recordings. Okay. And so it looks like we have a question from Camilla. How have pharmacy challenges such as the closing of pharmacies, staffing shortages impacted pharmacy initiated PrEP? Does any of our presenters want to take that one on?
I'm actually not sure how to answer that question. I'm sorry. However, I would be happy to follow up with this person separately when I'll or connect with my colleagues that are leading on that research. So my email address is it's on the screen. So feel free to reach out to me, and I'm sorry that I can't answer that question live. Okay, great. I see someone from DC Health. Okay, I would love to hear from you. Please feel free to reach out. Thanks.
All right, well, I'm going to jump in. I see that we are at time, and I want to be respectful of everyone's time today. So I would like to thank all of our wonderful speakers today, Tim Horn, Nicole Elinoff, and Dori Molozanov, as well as our fantastic moderator, Rodderick Sheppard. Again, my name is Maddie Helton. As we've mentioned, the slides from today's webinar, along with the recording, will be made available in the coming weeks on NASTAD's website. Other than that, we'd like to thank you for attending today's presentation, and we hope you have a wonderful rest of your day.